Hello and good evening to everyone. Thank you very much for joining me at this relatively late setup for a live. It's been a busy day for me, but I came across some information today from Thomas that I thought was so valuable that it was worth discussing. One of the difficulties that we have in COVID-19 is that we haven't spent enough time focused on the pathophysiology, the things that make the disease what it is. And this is what I have been focused on for the past almost probably 14 months, looking at the pathophysiology in COVID-19 and trying to analyze it and explain why it is that there are certain characteristics that are associated with the disease. And so this paper that was published just on the 1st of July, which I will just quickly share with you all, is extremely important. And I'm not sure why that has happened. I hope that's not flashing too much. Let me just unshare. Yep, there we go. That's much better. Yes, and so this piece of work that was done by the CDC, I'm very appreciative of. They have looked from March 2020 to March 2021, looking at underlying medical conditions and severe illness. And when you look in more detail, they have looked at 800 US hospitals across the USA to try and come up with the characteristics that are relevant with regards to COVID-19. They have a huge sample, over almost 4.9 million hospitalized adults, okay, of which 11% were patients with COVID-19. And when they looked at the details, 94.9% had at least one underlying medical condition. And this is the number that stands out. Hypertension, 50%. 50% with regards to hypertension. Now, I can't explain enough that that is not a pattern that we normally see in any other kind of infection. It's unbelievable. It's absolutely unbelievable. And so analyzing why this is happening is what we should have been doing for the past 14 months. We have taken our eye off the ball. We have missed a huge opportunity to try and understand the disease. And really, we can't afford to go on ignoring some of these factors. So let's go into a little bit more detail with regards to what it is showing. Now, I've picked this table here, and 540,000 to be specific. I'll tell you the exact number of patients. It was 540,667 patients who were hospitalized with COVID-19. Okay, and when we look down at this data, we can see that the one that stood out the most was essential hypertension. 272,000 people had hypertension. That was unbelievable. That is, I can't explain that we don't see that pattern in the context of viral infections. You know, you could argue diabetes is in the picture. Diabetes with complications, 171,000. You could argue that diabetics have a higher risk of infection, and so you would think that therefore that could explain why they may be more affected. But there is nothing here that makes any logical sense that hypertension would be the top in the context of a viral infection. That's important because what I have always said is that what we have is a viral infection that is affecting people in a specific way that causes a cytokine storm. That's really the question that we have to ask. What is it that could trigger a cytokine storm in people who have a viral infection with hypertension? That's the outlier. This one here is the one that stands out the most and is the most important factor for us to analyze. So I'll get into a little bit more of the graphs, and I will highlight another bit of detail when we look at the characteristics of patients who were hospitalized. And when we look at this chart, now I think I'm going to have to make this a little bit bigger so that you can see it a bit better. When we look at this chart here, let's see if I can find this. So that's probably a little bit clearer for you. One of the things that we need to understand is that when we speak of deaths in COVID-19, a lot of people make reference to the fact that people have comorbid conditions, they were at risk of death, and that's the reason why they die in COVID-19. But I have gone here and I'm going to look in a little bit more detail at the group that is the younger age group, because I think that that group is probably more relevant in terms of the details that we're looking at here. So let's look back at this here again. And we can see here that when we look at the age here, I want to break it down. Is this the right one? So we look at the 18 to 39 age group here, and we can still see that this age group here, 11% of them, that was a full sample who were hospitalized. Of that 11%, 7.7% ended up on ICU. IMV technically just means high flow oxygen. And this is the number here that died, 1.6% in the 18 to 39 age group. When you break it down, and this is the detail that I would have wanted to be able to see, which will be somewhere in the data, is that what are the characteristics of this 1.6% who are in the 18 to 39 group who have died? How many comorbidities are relevant to them? And based on the previous slide, we could see that hypertension and obesity would be the big factor that would stand out in this age group. And this is relevant because what it highlights to us is that we can almost pinpoint with very, very good accuracy who is at risk for severe infection. That's really, really important because in the context of severe infection, these are the people who are at risk of dying. That's what we need to be able to identify. And that's when we should be getting very targeted in all of our strategies, whether or not it's vaccination, whether or not it's inpatient or outpatient therapy. If we know who is most at risk, it really makes the job of doing everything so much easier. That's the piece of the puzzle that we haven't focused enough time on. And that's the bit that, again, I'm going to share a few thoughts with everybody about this. This is not going to be a long presentation because I think the points that we really, really need to do is focus on the characteristics of the disease. So when I have been doing my research, and I will take us back to the original chart in a second. The original chart that I showed, this was what was coming out of China at the time, except that their numbers at the time were 76%, not 50%. That was a red flag to me because I knew that hypertension is not associated normally with an increased risk of severe disease. So there must have been a characteristic about these patients that made them more at risk in COVID-19 than the other average person. Additionally, because no children or very few children had severe disease, that was another point, another outlying point that definitely stood out to me as being very, very important. And so I'm sharing again some of the research that had been done over the past year. And this is the point that I think that I need to clarify, is that when we looked at the information with regards to serum or plasma ACE2, this pattern in terms of hypertension, blood pressure, age, diabetes, weight, males, stood out as being so significant because serum or plasma ACE2, and I probably have jumped ahead. Let me just quickly clarify what it is. We know that the ACE2 receptor here is what the virus uses to get into the cell, okay? And we have known that for some time. But what we had failed to reflect on was the association with serum ACE2. That's the bit that many specialists or scientists across the world weren't aware of. And I was in that group. I didn't know about serum ACE2 either. It was only when I was looking at hypertension and trying to figure out why children weren't so severely affected, but people with hypertension were, that I stumbled into this. And this was the point. It was only identified in 2005 by Professor Anthony Turner in Leeds. And we don't know why it happens, but essentially this special ACE2 snipping enzyme, which is what called ADAM17, clips off the endothelial ACE2 and it floats in the bloodstream. And that's what we call serum ACE2. We do know that this can also bind to the spike protein on the virus. And if you look at this picture here, I probably have a better picture of the virus and the serum ACE2. This is all that we had said in our research, is that this is what we think is happening. The serum ACE2 is binding to the viral spike protein when it gets into the bloodstream, and then the body doesn't know the difference between the serum ACE2 and the viral spike protein and makes antibodies to both of them. And this was essentially all that has been said for the past year and a half. And I think that it's almost disappointing that this is probably not taken as seriously as I hope that it would, because my point is that people may argue that the theory is wrong. That's one thing. But we need to know that it's wrong. It's not good enough to think that it's wrong. We need to demonstrate that it's wrong. And more evidence is coming out that serum ACE2 is closely associated with severe disease as well. So it's not just in terms of risk, but even patients who are hospitalized have elevated levels of serum ACE2. That's a very important point. The other thing that needs to be explained, and I'm going to go back to the chart to do this, is the issue about gender or sex. Why is it that men are more affected than women? And the numbers here are quite stark. You know, they can't be ignored. So this is here, sex, female and male, equivalent numbers, actually more females than males in the population cohort. It's not much different in terms of whether or not the full sample of hospitalized patients, they're very similar in terms of hospitalization risk between men and women. But once we start to go into ICU, and whether or not they need oxygen or high flow oxygen, look at these figures. Suddenly they split away from 50-50 to 55.9, 44.1, 60.8 to 39.2, 58.9 to 41.1. Why would men be so much more affected in a viral infection? We never see that. That is definitely not a clinical pattern that we see. And these are the points that seem to have been missed when we speak about COVID-19. How we have missed these points, to me, is huge. We need to understand why these characteristics are there. And again, emphasizing my point, to me, again, the principle is simple. When we look back at the risk factors in terms of elevated serum or plasma or free ACE2, males much more than females, definitely in terms of their certainly a racial predisposition, obesity, diabetes, hypertension. The pattern matches. And this is why I keep on emphasizing the point that this piece of research must be done. This is part of the main reason why, as a clinician, I'm trying to have to do research, because I don't find that there is enough focus on trying to understand the pathophysiology of the disease. And as far as I have been concerned over the past year, there is nothing I have seen that changed my primary belief that the cytokine storm is an autoimmune response in the context of a viral infection with the levels of elevated serum ACE2. This is what I've been saying now for a very long time. And here's an interesting point that somebody made. Psychiatric patients have a very high risk of severe disease. And this is a very high risk group. And guess what? The medication that we have to use in many of the psychiatric patients do have an increased risk of causing hypertension and diabetes and cardiovascular disease. These are all the links that we see with regards to severe disease. Similarly, Down syndrome, there's a high risk with that. That's, again, a condition that is associated with cardiovascular problems. And so therefore, you are likely to see elevated serum ACE2 or free ACE2 in that principle. And just to highlight again, this is the overview of what we've said with regards to autoimmunity. Effectively, let me just make this slightly bigger. So effectively, what you have is free serum ACE2 binding to the viral spike protein in the bloodstream and getting taken up by the white blood cells or the macrophages. They are immune processed, and then the body produces antibodies, not just to the spike protein on the virus, but also to ACE2 or serum ACE2. And this causes a very severe autoimmune response in the lungs, especially of people who have been primed by this. And it's a hypersensitivity response, as Dr. Shetty has pointed out. It is probably a type 2 hypersensitivity response. And the research is seeming to suggest that when we look at the early phase, antihistamines are important because they'll stabilize mast cells, probably when the IgG antibodies are being produced. This is the critical piece of how we need to understand COVID-19. If we fail to understand it and we continue along this path of treating it just like a typical viral infection like flu, I think that we are destined to make huge mistakes in treatment, in terms of prophylaxis, protection, identifying, and it would delay our ability as a world to get back to some degree of normality. I'm just trying to see whether or not there are any specific questions here that people have highlighted. One of them here is about ivermectin and hydroxychloroquine. Again, part of the issue is that the research, all I can say is that when we looked at what happened in India, when we saw the cases plummet, when there was widespread use of ivermectin, I cannot understand how we could discount it, no matter what a blinded trial may say, because based on the information that I'm sharing, if you select the wrong group, meaning that if for whatever reason the group is young patients who don't have comorbidities, you'll not see a difference with ivermectin. You need to be using it in a group who has high risk. Similarly with hydroxychloroquine, I don't have time to go through the research, but I can bet that the studies that were positive would have been using patients with multiple comorbidities, and the studies that were negative probably weren't. And it's just because we're treating everybody as the same. This is an unusual situation. It requires different kind of thinking to what we're doing than we're doing now. Share my thoughts about how should treatment be based on age and comorbid conditions. I think that one of the points that we have to realize is that there is definitely a high risk of severe disease with regards to the comorbid conditions. And this is where vaccination comes in. The vaccination helps to reduce that risk in high-risk people. So based on what we're seeing here, you can see the characteristics: the hypertension, obesity, cardiovascular disease, especially in men, and probably even so in people who can, from a racial point of view, genetics, Blacks and Asians and Hispanics to a certain degree, there seems to be a higher risk because of the elevated levels of serum ACE2. So the vaccination definitely works and protects in that sense. But it then becomes a question of when we can see, when we look at these figures, and again, I bring them back up, and the figures are demonstrating that, out of 540,000 people, only 740 had zero comorbidities. That's critical. That's a really, really important point. That's 0.9% of the cohort. I'm not sure how this can be ignored. These are really, really important statistics, which is why I'm speaking about it now, because this needs to be highlighted. We need to relook at what we're doing and make sure that this fits within the context of what we're doing scientifically. There is I think another point that I want to make, and this is to do with immunity. I want to share, I'm going back to the original chart here. And we can see in order of frequency the conditions that are most associated with severe disease. We said hypertension, disorders of lipid metabolism, so high cholesterol, obesity, diabetes, heart disease. Esophageal disorders, I'm not quite sure why that's so high. That's another interesting outlier that should probably be investigated. Chronic kidney disease makes sense to me because you have a problem excreting serum ACE2. This would happen. Anxiety and fear-related disorders. Now that is really a fascinating outlier as to why this would occur. And this is really, really very important. Is it that these patients are on medication that increase their risk of heart disease? These are the things we need to look at. COPD doesn't surprise me, because if you have reduced lung capacity and you have a cytokine storm, it's going to be very difficult to get through that. Thyroid disorders, again, associated with heart problems. Depressive disorders, is this more, again, related to medication? Sleep-wake disorders, we know there's a strong association between poor sleep and cardiovascular disease. Are these just factors that are pointing towards that? Now, when we look at all of this, I want you to reflect on the fact that nowhere in this have we mentioned conditions that are immune suppressed. Rheumatoid arthritis, systemic lupus, patients on immunosuppression. This is a very important point. If the viral infection is the main reason for the cause of death, without a shadow of a doubt, we should be seeing much more severe disease in people who are immune suppressed, and we don't. And it's clear from the numbers that this is not about immunity. This is about an associated condition that, when it's combined with this viral infection, causes an extremely severe cytokine storm. That's what we need to target. That's what we need to focus on. That's where the answer lies. And again, I say, I don't think it's acceptable that we haven't got these answers as yet. We have spent so much money, so much time looking at a variety of things, but we haven't answered the fundamental questions. Simple. Why hypertension? Why children aren't significantly affected? Why are males 60% more affected? These are the questions that don't fit with any other viral infection that I have ever seen. Here's another question. FLCCC, 60 double-blinded studies on ivermectin, lives people do not need to die. I have great support for FLCCC because they have stood up for what they've believed in with regards to high-dose steroids from very early in the disease. And I think that that was the right approach. The challenge they're having with regards to ivermectin is that I think that ivermectin is almost being positioned too strongly as a miracle cure. The reason I say that is because if we don't understand the pathophysiology, how is ivermectin working? Because clearly, as I said, the immune suppressed are not affected. So this is not about the virus. This is about how the virus interacts in people who have hypertension, diabetes, and heart disease. How would ivermectin fit in that? That's where I think I've got the answer. Ivermectin is able to influence, it seems, the way how the virus can get past our mucosal immunity, and it prevents it from being able to block interferon, which is what the virus does. And so it gets down into the lungs even before the body has responded, and this is what triggers the very severe cytokine storm. In that context, ivermectin probably really could make a difference, because as a prophylactic, what it would do is that it would prevent the primary trick that the virus uses from working. And that to me makes perfect sense. Additionally, ivermectin is an immune modulating drug. So it probably is modulating the immune system when it is being triggered in an autoimmune response. And so similarly, we may find that hydroxychloroquine in the specified group could work. But we have to understand who that group is and then use these drugs appropriately. Similarly, vaccination will work most effectively in this group. It would then be argued, if only 740 people died out of the 540,000, only 740 with no comorbidities, it really does raise a question as to our risk-benefit analysis for the general population. These are really serious questions. There is a responsibility to make sure that we have assessed all of these points in a comprehensive and analytic way. And that's the purpose of what it is that we want to do with regards to McMillan research. I'll share this point again about what we hope to do with regards to raising funds to do the research that I think needs to be done with regards to COVID-19. I'll very, very quickly share this this little video to see if it can make the point as to why I've decided that this probably needs to be done, and why I'm trying to lead this charge for making a difference in terms of our understanding of the disease.
McMillan Research is one of the Vejon Health group of companies, which comprises health and media businesses. McMillan Research, along with Dementia Crowd Research Limited, and VibroScience Limited, focus on innovative medical research to find solutions for a selection of common diseases as well as strategies to manage them. At McMillan Research, we take a unique approach to medical research, applying the fundamentals of physiology and pathology to understand disease. Through detailed research on COVID-19, a theory of autoimmunity to angiotensin-converting enzyme 2, also known as ACE2, was formulated in April 2020. At that time, the hypothesis that COVID-19 is a viral-mediated autoimmune disease was not regarded by many as plausible. Over the past year, the theory of autoimmunity in COVID-19 has gradually gained credence. Dr. McMillan, Executive Director of McMillan Research, collaborated with experts to publish scientific papers in May 2020, explaining the concept of autoimmunity in COVID-19, and March 2021, proposing a more detailed and comprehensive explanation of the symptoms associated with COVID-19. The principle of autoimmunity in COVID-19 is that the viral spike protein binds to serum ACE2 to trigger an autoantibody response. This may lead to severe disease in people who have elevated levels of serum ACE2, including the elderly, and those with obesity, hypertension, heart disease, and diabetes. Sex and ancestry are also determinants of elevated serum ACE2. This theory of autoimmunity could explain the symptoms, timeline and associated comorbidities in people with severe COVID-19. A COVID-19 research project has been designed with the aim of advancing our understanding of immune dysregulation in COVID-19. This is the primary cause of lung damage which can lead to death. The outcome of the research project has the potential to change the course of the pandemic.
Yes, thank you. Well, thank me for sharing that. But that's the reason why I think this work has to be done. It's a lot of time, it's a lot of effort, and it's truthfully not necessarily where I wanted to apply my time and focus. Anybody who knows me knows my passion is about dementia and dementia research. But this is too important for us to leave because we can't move forward as a world if we don't have these kinds of answers. So thank you again, Sunita, for those kind words. Here's one more question, I think. Does the virus affect people more with lower blood platelet counts? Well, platelets are affected in terms of the severe disease, but it's not the reason that somebody would have the cytokine storm. And that's where we have to differentiate some of the blood tests that we would see from the disease. You may see some thrombocytopenia, but that's largely because of the excessive thrombosis that would be occurring in the lungs. So I think it's a secondary factor rather than a primary and linked factor. So thank you everyone for listening today. I hope this was of value to you. I will close out by again quickly sharing this principle. Again, we need to understand why essential hypertension is 50% of the causes of severe disease in COVID-19. This has not been a pattern that has ever been seen in any other viral infection. In this lies the answer to the disease, and we need to get that so that we can find and identify targeting strategies to make sure that we save lives across the world. Thank you very much to everyone who has been with us today, and I hope this was of value to you. Have a great evening, and look forward to our conference coming up on the 24th of July with regards to long COVID. We have a wonderful lineup of speakers from across the world, and click on the link when you see it coming up with regards to this fascinating conference on long COVID with almost 2,500 attendees already on LinkedIn. Have a great evening to you all, and we should certainly be bringing more live presentations to you over the next few weeks. Have a great evening.